Good afternoon, everyone. I'm Hancke Kock. Today I'm just going to take us through alcohol withdrawal management in rural and remote communities. With special thanks to the BCCSU medical writing team for helping me in supporting in developing these slides. So the learning objective is to identify and diagnose alcohol withdrawal using the DSM-5. And also we're going to utilize the pause tool to assess the risk of severe complications of alcohol withdrawal. And that will also determine our management pathway, inpatient versus outpatient management, and then discuss considerations for withdrawal management based on patient risk in the context of rural and remote and or low resource communities. So this slide is a review of the AUD clinical pathway. And this is how to visualize where withdrawal management fits into the continuum of care. So the AUD clinical pathway begins with screening and brief intervention. Individuals who screen positive for high-risk drinking do not have AUD are administered a brief counseling and intervention, but individuals who have AUD are assessed for the risk of alcohol withdrawal and will have a care plan tailored to outpatient or inpatient withdrawal management. And this is the topic of today's presentation. We're going to use the prediction of alcohol withdrawal severity scale, or the PAUSE scale, and that will be discussed in further detail later on in the presentation. And then if we look at the background, so if we look at withdrawal management, it's defined as a set of pharmacological, psychosocial and supportive care interventions that aim to manage withdrawal symptoms when someone who uses substances stops using the substances. So you can break up withdrawal management in about 3 categories. First, we have supportive care, for example, nutrition, hydration, a supportive environment. Then symptom management, if we look at, for example, over-the-counter medications for pain, as well as for nausea. And then the pharmacotherapies, typically benzodiazepines, anticonvulsants, or alpha-adrenergic agonists. So the choice of the pharmacotherapy depends on the level of risk, which I will also discuss further in the upcoming slides. It is important to note that, alcohol withdrawal is not alone, it's not adequate for effective treatment of AUD. So I'm just going to go briefly over the neurochemistry of alcohol withdrawal. Alcohol disrupts the balance of neurotransmitters in the central nervous system. It's an indirect GABA agonist, and it's increasing the inhibitory effects. And it's also a glutamate antagonist, suppressing the excitatory effects. So with chronic alcohol use, the brain adapts and compensates for the imbalances resulting from alcohol consumption. And then if you abruptly discontinue alcohol consumption, that can result in acute imbalances of these neurotransmitters, causing symptoms of alcohol withdrawal. So if we look at alcohol withdrawal, 2 or more of the following symptoms developing within several hours to a few days of the cessation or reduction in alcohol consumptions. We look at autonomic hyperactivity, such as sweating and a pulse rate greater than 100, insomnia, increased hand tremor, nausea and vomiting, and then the transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, anxiety, and then the one we're really concerned about, the generalized tonic-clonic seizures. So to meet the DSM-5 criteria, you have to have 2 or more of these symptoms present within a few hours to 2 days of seizing alcohol. So this is just a nice picture example of symptoms of alcohol withdrawal. Typically begin 6 to 24 hours after the last intake. and peak at about 24 to 48 hours. Symptoms generally resolve within 5 to 7 days. Up to 50% of individuals with long-term alcohol dependence would experience symptoms of withdrawal, and up to 10% of patients can usually develop generalized tonic seizures or DTs. So alcohol withdrawal seizures and delirium tremors are the most severe manifestations of alcohol withdrawal, and DTs can be characterized by severe confusion, disorientation, hallucination, and along with severe autonomic hyperactivity. And DTs occurs in about 3 to 5% of the population. This is another graphic of highlighting the timing and intensity of alcohol withdrawal symptoms. So if we look at assessing the risk of severe complications of alcohol withdrawal, not all individuals with AUD will experience severe complications from alcohol withdrawal. And assessing the risk of severe withdrawal symptoms can be useful in determining the appropriate withdrawal management pathway. That being said, that's inpatient versus outpatient, and also the pharmacotherapy options one is to use. All patients with diagnosed alcohol use disorder seek to reduce alcohol use should be assessed for the risk of developing severe complications of withdrawal. So assessing the risk of severe complications with alcohol withdrawal using the PAUSE scale, a PAUSE of less than 4, low risk of severe complications from alcohol withdrawal, and then a PAUSE of more or equal to 4, a high risk of severe complications. And then I'll just mention something about the CWA as well. That's more used in the inpatient setting, but a CWA of more than 15 consists of severe withdrawal. So this is just a look at the PAUSE specifically. So you have the threshold criteria in part A, and then it's a set of 10 questions, and then it assigns 1 point to a series of 10 questions. As mentioned previously, a PAUSE of 4 and higher indicates high risk for moderate or severe complications from alcohol withdrawal. So this is how we choose withdrawal management pathway based on the risk of severity of withdrawal symptoms. So being said, PAUSE of less than 4 can be connected to outpatient withdrawal management services. And then if additional pharmacotherapy is deemed appropriate, we prefer to use non-benzodiazepines, for example, carbamazepine, gabapentin, or clonidine, usually with a PAUSE of 4 or more. That's at risk for complications, so we tend to use more of an inpatient setting. So withdrawal management in outpatient care, it's usually medically supervised withdrawal management in like a primary care setting or an addiction treatment setting. Outpatient care is generally safe and effective for the majority of low-risk patients and more cost-effective. And this is also good for a patient's work schedule and family life. So then as we talking about the criteria for outpatient management, as I said, a PAUSE of less than 4. And then the contraindications, severe comorbidities, acute confusion, acute illness or infection require medical intervention, co-occurring serious psychiatric symptoms, pregnancy. You also have to have the ability to take oral medication, ability to attend daily medical visits for the first 3 to 5 days and alternate days thereafter, and support is usually quite important from either a family member or a community contact. Absence of any other medical or social condition would pose a risk to patient safety during the withdrawal management. So the AUD guideline provides a number of considerations for providing outpatient care withdrawal management. Consideration for outpatient care include schedule a treatment based on the patient's circumstances and available service coverage. So a good example of this is a patient starting treatment on a weekend to accommodate that patient's work schedule. And then it's also good to performing remote follow-ups where appropriate, for example, phone calls and video calls, and providing referrals to community resources, support groups or employees, and regularly reassessing the patient's treatment goals, monitoring for relapse and collaboratively exploring the cause and possible strategies to address it. So if during outpatient, if the cause cannot be addressed, for example, there's barriers to effective outpatient treatment and care, then one should consider moving over to inpatient care. So this is an example of the non-benzodiazepine treatment regimes. This is carbamazepine. As you can see, this is quite an easy treatment regime as it's quite fixed, day 1 to day 4. And as you can see, we start with a QID dose going down to a daily dose. I haven't used carbamazepine often. I have used it in the past, but you should just look out for individuals with severe hepatic disease, bone marrow suppression, as well as an AD heart block. Gabapentin, an example of gabapentin. As you can see, there's more dose variation with gabapentin. We start off usually with a 300 milligram TID dosing, and then the evening dose can fluctuate. This is this is not as straightforward as a carbamazepine, but this is my preference that I usually use, and it's patient tailored. So inpatient care should be provided for patients with severe complications from withdrawal with a course of like 4. And then inpatient provides continuous medical monitoring. And then it's also the supervised use of benzodiazepine that is recommended for inpatient withdrawal management. This is due to evidence that because of the side effect profile of benzodiazepine, as well as supervised use is recommended due to the safety profile of benzodiazepine, and I'll talk about that in a bit as well. So conditions that would indicate inpatient withdrawal management is required regardless of the pause score include multiple unsuccessful attempts, failure to respond to medications after 24 to 48 hours, unstable medical conditions, chronic complex pain disorders, and then the concurrent use of other CNS depressants such as Z drugs, benzodiazepines, liver compromise, pregnancy. And this is the withdrawal, with benzodiazepines, the withdrawal management strategy. As you can see, the first line is more of a fixed regime. We start off with a QID dosage, and then it goes down to HS dosage. I would just like to comment that benzodiazepines are contraindicated with patients with severe respiratory insufficiency, hepatic disease, sleep apnea, and narrow-angle glaucoma. Typically, we use benzodiazepines in an inpatient setting with continuous clinical support. Flexible dosing can be easily performed in a supervised settings where symptoms can be monitored and assessed, and symptom-triggered dosing has better outcomes than fixed dosings of benzodiazepines. This is just a quick image to highlight the rural areas in Canada versus the urban areas in Canada from Statistics Canada in 2021, and I'll have more details on the next slide. So in 2018, Canadians living in rural areas were more likely to report heavy drinking, 22.4%, compared to those living in urban areas, 18.4%. From 2021, the census, 17.8% of Canada's population lives in a rural area, and the population of rural area is noted here, and also what consists of a rural area. So it can be challenging to provide this inpatient care in communities where there's a lack of facilities that are able to provide this kind of care. Travel distance is a barrier to outpatient treatment. Rural areas may not offer special kind of detox and withdrawal programs for adolescents and other subpopulations. Rural women face more of a challenge, as well as Indigenous individuals are disproportionately affected by the substance use disorder, as well as Indigenous individuals in rural areas may face greater barriers to care. For example, the lack of recognition and respect from healthcare providers regarding cultural protocols and the history of racist intervention and racial stigma. And there's further studies that reported that higher levels of stigma relate to substance use disorder treatment in rural populations compared to urban populations. And then there's also another study found greater perceived stigma among older adults in rural areas in receiving psychological treatment, and others study among physicians found that rural physicians reported greater bias towards patients with substance use disorder compared to urban physicians. Okay, for patients who meet the criteria for inpatient withdrawal management but lack of access to available service, clinicians can provide support to these patients by providing or connecting them to services to support community-based monitoring, such as home withdrawal programs, intensive outpatient programs, for example, detox, and linkage to community pharmacy support system management. I also just wanted to chat about telehealth. May provide competency care, especially in rural areas where in-person visits are not feasible. Okay, so in summary, individuals in rural communities may face greater barriers to care. Alcohol withdrawal is the result of the neurochemical changes due to chronic alcohol dependence. The PAUSE tool can be used to assess a patient's risk of severe complications from alcohol withdrawal, and withdrawal management pathways should be tailored to the patient's risk of severe complications from alcohol withdrawal, with distinct pathways based on the level of risk. And in patients in communities that lack inpatient withdrawal management services can be closely monitored through community-based care. And that's just an example of the withdrawal management resources in the various regions.